Good evening. As a proud president of UNA, that's the United Nations Association of Westchester, I'd like to welcome all participants to today's critical program on inequities in maternal mortality globally as well as locally. The crisis around the COVID pandemic highlights how important it is to discuss inequity in maternal mortality. COVID has made all too real the inequities in healthcare. They have been acted out in the unequal access to testing, to care, and to survival. In April, I lost my beloved wife of 51 years to COVID at the height of New York's cases. It has become increasingly vital to me that we talk about inequities and do something about it. It was such a blessing to recruit Dr. Ronnie, who is our moderator today, and how quickly she and the program committee developed the idea to do something around this pressing issue of maternal mortality and inequities surrounding it. As women are assuming more and more prominent and powerful leadership positions in the United States and the world, we have to make sure that their lives are valued. This value must be extended to pregnancy and birth. Thank you especially to Colleen and Nicole, the chairs of UNA Westchester Chapter's Program Committee. Their willingness, commitment, and creativity in putting the panel together have been inspiring. It underscores the importance of the work of the United Nations and UNA USA. The United Nations Sustainable Development Goals directly address maternal mortality and point to the importance of reducing it. Whatever little we can do in our community will contribute greatly to this goal. We are blessed to have News 12 on Zoom this evening, and they are willing to do a special in October on this particular issue. So if you have any special things that happen to you, I'm sure on the chat, they'll give you the email address to, in particular, I forget her name right now, but it'll come to me. It'll come to me in the chat.
Kara Rosenblum.
Thank you, Ms. Rosenblum. Get in touch with her and give her your particulars.
Thank you so much.
At this time, I'd like to introduce our moderator, Lonnie Richmond, a midwife and midwifery educator. She has been my neighbor in Mount Vernon, and we have worked together in our community organization, Neighbors That Care, for the last 18 years. Ronnie, thank you for being here, and I pass it on to you. Thank you, Ronnie.
Thank you, Yana. Thank you so much. I'm humbled to be the moderator for this important conversation today. I echo your sentiments, Yana, and I also want to thank the very talented and committed program committee that I was privileged to work with in putting this together. I also know I speak for all the participants here today. Yes, you can't hear me? I'm sorry. I know I speak for all the participants here today, Yana, in extending our deepest condolences to you in your loss. And this is a loss that tragically shows the human side of inequity. And that's exactly what we will be discussing today: inequity in maternal mortality, inequities that disproportionately affect women of color. Experts estimate that 60% of maternal deaths are preventable. The reality is that women should not die in pregnancy and childbirth. And the shocking and unacceptable inequities in these death rates, and inequities similar to those in newborns and infants, mirror our overall society and societal inequities. It's especially noteworthy to have this conversation in 2020 for two reasons. One is that at the beginning of 2020, the World Health Organization declared this the year of the nurse and the midwife. Midwives have been put forth as an important, a vital component as part of the solution to reducing maternal mortality and inequities. The other reason it's so important to be having this conversation in 2020 is much sadder. It's because of the COVID epidemic that Yana referred to and its effects on maternal mortality and on maternity outcomes in general. Let me briefly just tell you what the format of today's meeting will be. We will start with 4 panelists, 2 of whom will speak on global issues and 2 of whom will speak on local issues, both of whom work in the lower Hudson Valley right here. Please read their bios that were in the flyer that were sent to you. I will introduce them very briefly in the interest of time. While they are speaking, please use the chat box to enter your comments and your questions. We will read these at the end of the panelists' presentations, as many as we can given the time constraints. We will attempt to answer all of them afterwards because they are all important. Speaking of importance, after the question and answer will be the most important part of this, is just where we hear all of your voices, because your voices are imperative. We will break up into moderated small groups. We will then regroup, and each group will have 1 to 2 minutes to present. Can I have my slides, please, just to give you a little background information? Slide 1 shows you the Sustainable Development Goals that call for a reduction in maternal mortality to lower than 70 per 100,000 live births by the year 2030. That seems very doable, but if you look at my next slide, we're very far from that goal. And I'm just going to point out 3 lines on this slide. I want to show you the first line rather, which shows the world rate, which is 211 right now, 3 times the Sustainable Development Goal. If you look at the last line, the least developed countries, 415, which is almost 6 times the goal. You look at the second line, 542, which is close to 8 times the goal. So we are far from that goal. You look at the next slide, we come to the United States, where the relative mortality is shocking between Black women and white women. This slide speaks for itself. The third group of bars show you the Black women. The first group shows you the white women. 3 times the mortality among Blacks, and it's worse in New York State. If I were to talk about New York City only, it would be 8 to 12 times. Shocking, shocking, shocking. And this cuts across class and education. Women with the equivalent, women with at least a college degree have 5.2 times the mortality of their white counterparts. There's only one explanation for this, and that is racism. So given that we have this background, I would like to introduce our panelists. I'm going to just tell you very briefly about each one. Our first panelist, Annika Knudsen, is a midwife and the Chief of Branch of Sexual and Reproductive Health for the United Nations Population Fund. Our next speaker is Dr. Padmini Murthy, an obstetrician gynecologist who is a professor and the Global Health Director at New York Medical College. She is also the Global Health Lead for the American Medical Women's Association. Our 2 speakers on local issues, one is Angela Campbell, who is the Executive Director of the Lower Hudson Valley Perinatal Network, and Nubia Martin, who has a master's degree in midwifery, is a doula, a certified lactation consultant, facilitator of the Chocolate Milk Cafe in Yonkers that supports Black women in breastfeeding, and founder of the nonprofit Birth from the Earth. So among the 4 of them, we have a wealth of experience, knowledge, and wisdom in both clinical and advocacy work around women's health. And I'm so happy to present first Annika Knudsen.
Thank you so much, Ronnie, for that introduction and for the introduction of the global situation. I'm really so very happy to be here as a representative for UNFPA, the agency, the UN Agency for Sexual and Reproductive Health, in this very important discussion. And especially happy because it is, as you say, the year of the nurse and the midwife. And we have decided it's the decade of the nurse and the midwife. So could I have the first slide, please? I'm talking about the global, but the global requires a local perspective. And the local perspective entails my personal story for why I'm where I'm today. As a young girl living in Ethiopia, my father one day came home from the field in shock, as he had found a young woman by the side of the road, pregnant and heavily bleeding. He had to deliver the child right there, and he was no doctor. The baby was dead, but he helped save the woman as he put her in the car and took her to the nearest health clinic. I heard and I saw him in tears, and I knew in my heart this was wrong, and I wanted to set it right, and I became a midwife. Next. Next slide, please. UNFPA's goal is to attain universal access to sexual and reproductive health and rights for all by achieving 3 transformative results. Next slide, please. Ending preventable maternal mortality is one of the 3. To reach that goal by 2030, we've already seen the big gap that Ronnie was showing. And it means that developing countries must accelerate their annual rates of reduction by at least 7.5%. And at the same time, we know that individuals in Sub-Saharan Africa, Southeast Asia, and Latin America, the global majority, does not have equitable access to services nor quality they have the right to have, and accountability is missing. Next slide, please. But it is their right. Not only the right to services, but a multi-sectoral approach is needed. The main cause of death among young girls 15 to 19 is maternal mortality. Due to the lack of education and information, discrimination and stigma, lack of contraceptives and access to safe abortion, all of which could have been prevented. Next slide, please. But we need to make sure also that it's not only about survival, but the right to stay healthy and be happy, and to make a birth a happy life event. Discrimination of women, male dominance in health systems, and racism are drivers of inequality, abuse, and death. Next slide, please. Lack of quality of care is a poverty indicator, not only the provision of quality services, but also the experience of quality, a respectful maternity care that every woman has the right to. And when quality is lacking, it generates fear, fear for seeking care. And in COVID times, there is even more fear of getting infected and causing others to be infected. Next slide, please. Midwives and nurses are women too, and they are exposed to the same structural discrimination as the women they care for. But sometimes we tend to forget that. They need protection of their rights too. Next slide, please. And they risk their lives at the front line, as we have seen so many dying in the current pandemic. And what has been astounding is that the counting of the death among health workers has been mainly about how many doctors who've died, not how many nurses or midwives. Next slide. Let me therefore call upon you all, because we need to act together in partnership to get the adequate funding in place. And that means domestic funding, international aid, private sector resources, to get programs to scale so that we can reach everyone. Discrimination, racism, sexism cannot continue to cause any more women, girls, and their newborns to die unnecessarily. There is still a mountain of unfinished business for us to do. We know what to do and have known for a long time, and still, this young woman on this photo cannot stop thinking about whether her pregnancy will take her life. Let us never stop, never forget, and never assume that it is done until it is done, and all are safe, and no woman is discriminated against. Thank you.
Thank you. And now we'll hear from Dr. Padmini Murthy.
Thank you so much. Good evening, everybody. Thank you to UNA USA for this opportunity. And why are we sitting here in 2020? Because we're still focusing on the horrific maternal mortality and morbidity rates globally. And this is something which got me thinking a long time ago. And when I was a girl growing up in India, when I was a medical student, the reason I decided to train as an obstetrician is because I once had to deliver a baby getting onto a tractor because they called us and we went running. She was coming from so far, just as the previous speaker said. And one of the reasons is there were no gloves. So guess what? I was a Girl Scout. So I used some plastic bags, and you know, the environmentalists may crucify me, but hey, the plastic bags were there then. This was in the 80s, mid 80s, and I delivered the baby. So that got me thinking, if she had access and she was with a healthcare center, it would have been a different story. Thank God the baby and the mother survived. So I just wanted to start off by saying how this is an inequality. This is a violation of human rights, and it's both a systemic and inequality and racism. May I have my first slide, please? So when we look at these rates, now this is so sad that in the United States of America, look at our rates. And the reasons for this is, according to, so many studies and reports, is the number of people with women with chronic diseases, especially those in the minority, like the Black, the Hispanic, Native American, and some Asian women have very high rates of diabetes, hypertension, which are often undiagnosed. And also, as I mentioned, there is an racism, and now I use the term institutional racism, especially when it comes to dealing with the minorities in the United States. So you can see that these are some of the factors which give rise to the increased rates of maternal mortality rates in the United States. And we spend so much of money on that. The other issue is a lot of women are not aware of the consequences, like if they have a headache, if they have a little bleeding, they don't have access, or they don't realize that they immediately have to seek medical care. And we have mental health issues. We have, an increased risk for women in pregnancy due to hormonal changes who may have mental health issues which go undetected. Opioid addiction, as we know, is a major challenge in the US, and we have fragmented healthcare. So I just want to say these are some of the factors which contribute to the high rates of maternal mortality in the US. And we spend a lot of money, but again, unfortunately, we don't have specific policies here which address maternal mortality. And a study released in 2018 found only 45 states in the US and the District of Columbia had actually a policy to address maternal mortality rates on books. While other countries, you have better maternal audits, you have a medical audit. So if they, for example, in the United Kingdom, if a woman loses a life during birth, it is investigated much more than it is here. Next slide, please. So that being said, now I'm just moving on to the global picture. And the reason I discussed about the US is just to highlight what is going on. As we know, the social determinants of health, it's where you live, where you are, and also the socioeconomic and political context, which unfortunately, in camps, in areas of civil unrest, and now due to the current COVID, the already fragmented healthcare systems have really placed a double burden. So if you are a woman who is colored, poor, you don't have access. So you're at a triple whammy. And wrapping up, I just would like to highlight something what happened in India because of COVID. Next slide, please. The hospitals were closed. And one of the reasons is they did not allow anybody to come in. So these women who had children could not get the necessary, resources, including even sanitary pads when they have given birth. So to wrap up, ladies and gentlemen, everybody on this webinar, we need to have local activism with a global impact. We can make it happen because maternal mortality is horrific and there's no cure for it. Thank you.
Good evening. I'm so glad to join this awesome and powerful panel of true movers and shakers who's going to take on this racist and sexist institutions that put in jeopardy the health and safety of our pregnant women. Being on this panel gives me strength and hope that we will do this work and not be addressing maternal death 20 years from now, because this is important work that we need to handle at this time. As many Black women, I do not have a rainbow and unicorn birth story, because in Brooklyn, we didn't know about holistic health care or the history of our people having natural, safe childbirth. I cannot change the past, but I can change the trajectory of these women, of these Black women who need us and stand up for what they need. Because as Beyonce says, it is one of the most powerful activities to have, the most powerful creation is to have life growing inside of you. There's nothing bigger than that. Let's start by acknowledging that New York State pregnant Black women feel disrespected, inadequate, and invisible, and tell stories that show that providers have implicit and explicit bias. We have come to understand that many Black women in our communities don't think of childbirth as a happy experience. Because of structural racism, our moms can't find Black and brown doulas and midwives, don't know what holistic resources are available in their communities. And since doulas are not fully integrated into maternal care, we don't have the perinatal support that we need. At Lower Hudson Valley Perinatal Network, we are using collective impact to provide holistic, authentic community connections to coordinate clinical, social service, and other grassroots organizations to improve perinatal services for women of color. We are committed to stay with a pregnant woman every step of the way. To decrease the incidence of preterm births, we are teaching and reaching and motivating women to make a birthing plan, to learn to trust, and to feel safe. We do powerful parenting journey workshops where you need tissues because it's all about healing. We also have Our Babies, Our Future Collective Impact Coalition that integrates the Department of Health, Healthy Families, and MISH collectives and collaboratives. COVID-19 put a spotlight on what was already wrong with our reproductive injustice system. The social determinants of health and disparate burdens of chronic medical conditions are contributing to the worst COVID-related outcomes in Black and brown women and socially stressed communities. Physical contact made our women feel connected, cared for, and feelings of isolation were reduced. But since March, Lower Hudson Valley Perinatal could only do virtual home visits. Sometimes our pregnant women were in physically unsafe conditions. DSS reported that less than 60% of the calls were made prior to April. How can we get pregnant women immediately involved in intervention if we don't even see them? We had to change. So when our families reported food insecurity, we stood in line, obtained the food, and delivered it to their home. When a pregnant mom reports that she tested positive for COVID-19 and had no support, we ran the errands for her so she could self-isolate. When several pregnant women could not find diapers or formula or feminine products, we worked hard and found these items and delivered it to our moms. One of the hard stories for us was when we had a mom that was ready to deliver in March, and suddenly her husband lost his job. So they didn't have money to buy the child seat. She called us during her delivery and said that they told her that she would be going home the next day without the baby because they didn't have a child seat to give her. She felt terror. She didn't want to leave her baby in this hospital, especially with COVID and not understanding what was happening. But we cannot be distracted by these public health problems. So what we did was we found the child seat for her, we found the funding, and we got her a child seat. But we know that when it comes to reproductive injustice, it's further magnified by the US Senate, who went home for 40-day vacation without concern for the thousands of pregnant women who are worried about their health and food and paying their rent. The good news is that just before COVID-19, there were 9 comprehensive bipartisan bills for Black Maternal Health Mama Bus Act, the HR 6142 and the Senate S 3424. And these were started by, for the Senate, Senator Harris and Gillibrand. So they were sponsors on this bill. These bills move to invest in social determinants of health, not just talk about them. Since social determinants determine where we live, our educational level, our employment opportunities, we need to break these racist cycles and begin to have full health care that covers from preconception to postpartum. These bills seek to do just that. They provide stable housing, transportation, quality health care, healthy foods in these communities, reduce environmental racist issues like mold and mildew and all of these things that prevent children from going to school if they have asthma, and also looking for how to help women with behavioral issues as well. To fund community-based and community health organizations is to improve the maternal health for Black women that we seek. In New York State specifically, Governor Cuomo enacted a budget with $8 million investment in Black maternal health. He also established 2 New York State task force on maternal health and racial outcomes. To begin with, Governor Cuomo promised that his administration would listen to Black pregnant women. And that became true because he had 7 listening sessions through the Department of Health, all through New York State.
Angela, I think that's a great place to try to wrap up. Listen to women.
Yeah, okay. And we were pleasantly surprised that they were looking for women that do community health. So we are interested, and we will talk later in our breakout rooms about how to be empowered in our communities. Thank you.
Thank you. Thank you. And now Nubia Martin.
Yes, greetings. I am very grateful that we're having this very important conversation, because while maternal mortality and morbidity rates tend to be dropping overall, they continue to rise for Black women. And we need to recognize this as a crisis. And the way in which we address this is to have frank and open conversations like the one we're having today that highlight and address systemic racism and implicit biases as the root causes for Black women dying. I think it's important that the narrative of Black women are dying, pregnancy is scary, that we change this narrative and that we explain to the community members that there's nothing inherently wrong with Black women that puts us at a higher risk of dying, but it's more that we are experiencing inequities and inequalities and systemic racist systems that result in us not faring the same as our white counterparts. I want to talk a little bit about the height of the pandemic and how switching over to telehealth impacted the women and the families and the communities that I'm dealing with. So at the height of the pandemic, when we began to move to telehealth, the pandemic seemed to amplify all of the inequalities that we were already dealing with. And the issue with switching to telehealth is if you haven't been including your clients and your patients as an integral part of their own care, just giving them a blood pressure cuff and telling them to check their own fundal height is not going to be adequate. And this is where midwives come into play very importantly, because that is part of the midwifery model of care. Teaching a mom to place hands on her belly and assess fetal position, telling her about fundal height. So when we had to switch over to that type of care, it wasn't a big jump for us. But for the many populations that this is not the care they were receiving, this was extremely stressful for them because they were falling through the cracks in terms of getting the care that they needed. I'd like to talk about a particular family that reached out to me at the height of the pandemic in April. And at this time, this young woman's due date was May 30th. And she was switching over, trying to see if she could switch over to home birth care. And she had not been seen since December. And telehealth visits had taken over, and she was not being listened to. And this is something that we hear over and over again in our communities, that not only are Black women not being listened to, their voices are not being valued. And this young woman knew that something was wrong, and she was hoping to get a consult to switch to home birth. And one of the first things that I said to her was, how have you not been seen for all of these months? And you need to get your prenatal records so we can make sure that you're a good candidate for home birth. The very next day, she reached out with her partner, provided her records, and the first thing that I noticed was that her platelet levels were extremely low. And they had been low since December, and no follow-up had been done. So I told her that she needed to immediately get care, and she had to reach out to a local hospital that was connected with the hospital where she had not been receiving in-person visits. And when they realized how low her platelets were, they brought her in immediately. They opted to give her an induction on April 20th, and the induction failed, as they often do when someone is 35 weeks along. And they rushed her in for an emergency C-section where she didn't survive. Her name was Amber Rose Isaac, and she was 26 years old, expecting her first baby and extremely excited for this event in her life. And the fact that she didn't survive this, the fact that 4 doctors signed off on her care from December through April without following up on this crucial blood work, and the fact that her death was preventable is something that I'm continuously working to address in the community work that I do with my nonprofit organization, Birth in the Earth, with Chocolate Milk Cafe, which is another organization that seeks to bridge the gaps between breastfeeding rates for Black women and women of color, as we often have lower breastfeeding initiation and duration rates, which also results in a higher infant mortality and morbidity rates. So while we're dealing with maternal mortality and morbidity rate disparities, we're also dealing with infant mortality and morbidity rate disparities for babies born to Black mothers. So I wanted to talk a little bit about some of the things that we have in place to engage the community, make them an integral part of their own care, and to reduce some of these disparities that we're seeing between Black mothers and their white counterparts. So Birth in the Earth seeks to provide access to care. We train birth workers. So we know that if we have more birth workers, midwives, doulas of color, we will see a reduction in disparities for Black mothers. So we train birth doulas, postpartum doulas, childbirth educators, as well as lactation consultants. We also have created a Black Coalition for Safe Motherhood that I sit on the board of. And in that, we ask families to help to advocate for themselves. And we do this by asking them to ACT. And ACT is an acronym that stands for Ask Questions Until You Understand the Answers, Claim Your Space both physically and mentally, Trust Your Body, and Tell Your Story. And this work is very important to me because I'm the mother of 5, born and raised in Yonkers, and I dealt with my own systemic racism and biases during my pregnancies. In my first 2 pregnancies, I gave birth in a local hospital in Yonkers. And with my oldest daughter, I was told if I did not give her formula, I would be going home without my baby. I was 23 years old. With my second hospital birth, they brought me the wrong baby to breastfeed. So I continuously want to make sure that these are not problems that are being continued in our community. And the way that we do this is that we do a call and response. We engage the community and ask them, what are the things that they want to see? And they want to be heard, they want to be valued. And I think when we address these issues as what they are, a crisis, that we can come together and seek ways to topple systemic inequalities that see our women dying at a higher rate. And I thank you.
Thank you, Nubia. Thanks to all our panelists. And we will now look at the chat room, and Colleen will be reading some of the questions, and then I'll be asking our panelists to address them.
Yes, hi everybody. We have a lot of great questions. Let's see. Leslie Farrington has said, please address the medicalization of birth in the US, where 90% of births are with obstetricians.
So I'm going to ask Nubia to answer that because Nubia has a degree in midwifery. I don't want to say it, but I'll say it. Nubia was my student.
Yes, thank you, Ronnie. Yeah, so that is definitely a glaring fact that sticks out. And one of the things that we try to educate the women in our communities is their options and choices for where and how they birth and with whom. So we know that out-of-hospital birth is actually safer for those who are experiencing a low-risk pregnancy. About 85% of pregnancies are low risk. However, 98% of births take place in a hospital. So we're trying to normalize looking into other options, such as birth centers, such as hospitals that have midwives on staff, and also home birth, and normalizing that for women in the communities, especially for Black women, because I think that has not been something that has been spoken about enough, that we've had enough conversation about. But after my 2 hospital births, I went on to have 3 amazing home births with midwives.
Thank you. Thank you. Colleen, next question, please.
Lisa Burton has asked, why do you think the US does not investigate birth deaths? Is it due to potential lawsuits?
Dr. Murthy, can you respond to that?
Thank you. I'll try my best. I think you have a point there. And one of the reasons is also our rules are not that stringent when we are reporting the deaths when compared to other countries. And I posted that on the chat box. that the Government Accountability Office did come up with a report which was just posted in March of this year, 2020. It could be due to the lawsuits. And let me share something else. People like myself and some of my other colleagues choose not to practice obstetrics anymore because of the lawsuits, and there's no safety net. So I would say it's a conglomeration of so many factors. But if you ask me my 2 cents, 2 pies of earth, I'm Indian American, I would say it's because of a woman giving birth. If a man had given birth, it would have been a different story. So, you know, it's not that we are bashing men here, but it comes down to the gender bias and gender discrimination. Thank you.
Thank you. Colleen, another question?
Yes, two are similar. Brenda Smith asked, of our panelists, how many of you are familiar with Mama Kits, a project in which the Links were involved some years ago? How can organizations such as the Links and others make a difference in addressing many of these critical concerns that you share today that would in fact make a difference in improving the important issue and concern? And then Cheryl Brannon added another similar question. Sister to Sister International produced a report in October 2019, Still I Rise, the status of Black women and girls in Westchester County, that includes a review of maternal health. We have a maternal health work group that is making specific recommendations in Westchester. So she wanted to know if people were aware of that and how nonprofit organizations can assist, as Brenda was asking.
So Angela, can you please, since you work with a nonprofit and you do a lot, can you please address that, those questions?
So I think what's important is that we leave here with work to do. So I think being a part of organizations like the Links and Sister to Sister International, which I've been a part of for over 20 years, I think this organization in Westchester is looking at how we can better serve the community. They have done Mama Kits. My daughters grew up giving out Mama Kits at their schools and selling them. So I think getting even youth, Gen Zs and millennials involved in this as well. It has to be intergenerational. And I think that when we look at organizations like Sister International, they give the blueprint for what we can do. Yeah. They have intergenerational workshops where they allow young people and older people to come together to look at these issues, to discuss them, and to come up with a plan of how we're going to address them. So I think that the work is being done. We just have to make sure everyone knows about it.
Right. Thank you.
We have a question from Liliana Yazir Reed. Is there research on stillbirths, infant loss, or miscarriages in regards to pregnancy care among Black women?
So, Annika, can you address that question, perhaps from an international perspective or a national, if you can?
So I guess the question was meant regarding in the US, and I know that there is a group of researchers at Columbia University that is currently very much involved in doing research on the reasons, the different reasons for the very high maternal mortality among Black women in the US. And what I think will be a very important result coming out, it's preliminary, but what they see is all of the reasons for the higher rates of maternal mortality that you all have spoken about tonight. But in addition to that, they see a physiological toxicity emanating from racism that causes heart disease, that causes thrombosis in postpartum in women. And I think this will be something that really needs us to connect racism and the health outcomes more directly. At the international level, of course, yes, among all population groups, we support the study of data on stillbirths, miscarriages, and the disaggregation between indigenous populations and the general population, as well as age disaggregation in those cases. Thank you.
Thank you. I think we have time for at least one more question.
Okay, yes, I think we we'll try for 2 if that's possible.
Okay.
Tara Rosenblum with News 12 is asking, Nubia, can you tell us your initial reaction to the death of the 26-year-old mom from the Bronx? Do you think she would still be alive if she were a white woman? Was she the victim of systemic racism in our healthcare system? Why is the problem seem to be so bad in the tri-state?
It's a heavy question. I do feel that more attention would have been paid when she was saying that she felt something was wrong months in advance. And it really shouldn't have taken a consult with me to address the issue if she had doctors looking at her blood work over those months. My reaction to her death was obviously shock, anger, hurt, but it also spurred me into action. And I realized that even if her blood work had been squeaky clean, if her records were perfect, even if she wanted a home birth, she might not have been able to have that because insurance doesn't cover home birth the same way that it does hospital birth. So one of the things that myself and her partner, Bruce McIntyre, worked on was creating an Access to Home Birth Scholarship Award, which is in place through my nonprofit, so that if somebody is a great candidate for home birth, desires to have a home birth with midwives, that they are able to apply for the scholarship that will offset some of the out-of-pocket expenses so that finances is never a barrier to somebody having the birth in the setting that they desire.
Thank you, Nubia.
Can I add something to that from a more global perspective?
Sure.
Is that okay?
Yes, please
Sure.
do.
And it's not responding to the case that you had, of course, but I think that what we in UNFPA, we're working very hard to do is to, in countries where midwifery is not yet established, is to really promote a system where it's midwifery-led care. Because we know that when it's midwifery-led care, no matter whether it's in hospital or at home, we see that the voice of the woman is more easily heard. The woman is closer, the midwife is closer to the woman, and we appreciate the normality of giving birth, but also acknowledge the complications more closely.
That's right.
Ronnie,
Okay.
I have a question from Shane. He says, please tell us men how we can be valuable allies and assets in this battle. As usual, we need clear marching orders, please.
So Angela, can you give some clear marching orders?
Certainly. Well, I know Shane very well, and
Oh.
he's a millennial, and he cares about women and the outcome in their health. So I think men need to listen to women. I think that was the most important thing we learned in 2019, that pregnant women felt that they weren't being listened to. They felt they were being talked at and given advice, but not hearing their heart, not hearing what moves them to want to trust someone. Because if trust is established, then we can do everything that we need to do. But we're not set up in these organizations to build that trust over a long period of time. So I think that as men, you can join organizations like Sister to Sister, like the Links, like others, and find out, go to those meetings and find out what these women want. I think that's the most important advice I can give any man.
And can I just add, briefly also,
Sure.
just to be a part of the care that they're receiving, go to the childbirth classes with them, go to the appointments if you're able to, ask questions as well, whether it's your wife, partner, sister, aunt, cousin, you want to be involved. The more people that you have advocating for somebody who is pregnant and planning to give birth and wanting to survive that, the better. So that's how you get involved. You listen, you ask questions, you inform yourself so you can make informed decisions.
I know
Can
I'm just.
I say something?
Yes.
Yes, go ahead.
Yeah, thank you. Thank you. Just to add on to what both of you said, it's very important, like at least one of the things I do is I tell my male medical students and medical residents like to show compassion and put yourself in the place, because you cannot say, oh, those conditions, because you talked about Nubia Amber, that, you know, this is pregnancy related. So no condition is too trivial. You need to pay attention. You need to show empathy. You need to make contact. So, and the same thing with men, you know, take some time. Look at what UNFPA has. Look at what WHO has. Look at what we have in our own state here and New York City. So educate yourself, reach out to UNA USA. We are happy to work with you because we need men, and men are in the spelling of women. So we all need to work together to make sure that we advance maternal, safety and decrease maternal mortality. Thank you.
I know I'm just the moderator, but I'm going to add something. As a midwife, my favorite prenatal visits are when family members come, particularly the father of the baby. Those are the visits that I personally feel most excited about and happy about. And it's wonderful to see that family interaction. We have time for one more question. I keep saying
Okay.
that.
Great. We have a question from Kate Permut. She says, is there a way to use New York State legislation to force insurance companies to cover home births, midwives, and doulas?
So anybody can answer that question. Angela, I know you were talking about legislation. Can you discuss that?
So in New York State is very interested in reducing the cost of healthcare. So about 2 years ago, they started just a bit when all organizations can come together and they can figure out how to take care of the patients from preconception to postpartum. So I think the way to get insurance companies involved is the men, the women, everyone needs to call the task force because they do take questions. You can go online, you can tell them what you want to do. They have meetings, you can go on, they do them virtual now. So I think we have to not just end this day, but know that we need to continue to reach out to the governor to find out how to get on the task force. There's two, there's one for COVID and one for maternal health, and find out when they meet. And his secretary is the one who runs these COVID meetings as well, and also the maternal health one. So if we could just have everyone just remember to stay connected, I think that's part of the solution. And also the Senate, call them and get this Black Mama Bus passed through. It happened right before COVID, so they're not even talking about it. But now I know Senator Harris is a little busy, but I would call her office and because she's one of the co-founders of this legislation as well.
Thank you.
Yes, and I just wanted to add that when you're calling, these insurance companies or your legislators, put an emphasis on the fact that we need to stress that we need to stress people over profit. That is really important, and that behind all of these statistics that we're talking about, there's a family, there are people who are left behind who have to deal with this. So it's not just numbers, it's also the families that are being impacted by these deaths or near misses as well.
Okay, so my timekeeper, do we have time for one more question? Is there a short question?
Yes. Let me see. Renee and I can't see her name on this. Arioyo, sorry. How can we get the medical institutions to take pregnancies seriously? And Minnie had started to answer that in the chat.
Minnie, can you answer that?
Well, in the 10 seconds I have?
Yes, in 10 seconds.
Well, I think it starts as a teamwork, it starts across, and it is physicians advocating, it is health providers working. And again, let me give a shout out to my midwife and nurse colleagues. This is not a competition. We have to work together as teams. So that is the thing. If there is an observation made by a midwife or a nurse, an MD can't dismiss it the same way an MD cannot, a nurse or a midwife or cannot dismiss what the MD says. So I think it starts with working together, and we need to have a policy change. And hopefully, with the bill which was proposed by Senator Harris and her colleagues, these kind of things start. We need to lobby, we need to, be advocates. And I always tell my students, advocacy is like a hormone, it's pulsatile. It makes its effect known slowly but surely. So that's what I would say. We have to talk. I mean, for instance, I talk to my boss, I talk to my superiors, and at AMBA, American Medical Women's Association, we've been around for 104 years. This is what we do. One of the things we do is we advocate for better healthcare and better policies, and it has to be done collectively. Thank you.
So I just want to say something. We were told that State Senator Andrea Stewart Cummings is in the room, and I just want to recognize her because she has been a very, very strong advocate for women's health in New York State. Are you here, Senator Andrea, Senator Stewart Cummings?
Cousins.
Cousins, I'm sorry, excuse me.
Hi, my name is Laura Manara. I'm representing the Majority Leader tonight. She had an event at the same time, but I am here listening to everything that's being said, and I will, be sharing all the information with her as well.
Thank you, thank you. And now I think in a few moments, we have 20 minutes for our breakout groups. Did you want to say something very quickly, Annika, before we do that?
Yes, I just wanted to add to Minnie to say that my country of origin, Sweden, we have a system where all medical students are trained by midwives in the Obsgyni. And so that makes the collaboration much stronger from the beginning.
Thank you.
And I just wanted to briefly, if I could, Ronnie, add just locally, piggybacking on what Minnie said, we do need to all work together and have some hard conversations about if a hospital has an exceptionally high C-section rate, that needs to be addressed. If they don't support VBACs, that needs to be addressed. Because even if somebody wants to have a home birth, if their pregnancy becomes high risk, we need a safe hospital to transfer them to. We need to be able to have safe care all across the board in all birth settings.
And that information is available, the C-section rates from any New York State hospital. So now we're going to, in a few moments, break out into our small groups. We have 20 minutes for discussions. Each group has a moderator and will assign, I hope you volunteer to be a recorder and a reporter. When we get back, each group will report for 1 to 2 minutes. And we hope the breakout sessions will focus on action and steps that we can take, small steps, medium steps, large steps, local, national, international, but that we focus on actions. And when you return to report, give us 1 or 2 actions that your group has focused on. I'm going to call the name of the group facilitator, and whoever was the reporter in that room, please report. So Annika, I know you have to, you're probably exhausted. Annika's on a different time clock. So we're gonna have your group go first. And who's the reporter for Annika's group?
That would be me.
Okay.
Hi, Ronnie.
Who's me?
Me, Jack.
Oh,
Jackie.
Jackie. Hi, Jackie. You made it.
Jackie Greenfield. Yes, I did make it. So Annika's group consisted of several of us who spent a considerable amount of time discussing the midwifery doctor relationship. This had come up during the initial discussions this evening. That basically, it's an unequal relationship. We felt that midwives should be much more involved in residency programs, that ACOG needs to promote midwives as the primary caregivers of normal birth, and that midwives need to teach 1st and 2nd years, as is done up in Massachusetts at Bay State. Culture, I'm just going to go in order because we did jump around a little bit.
Just 1 or 2 more points because we have 10 groups.
Sure. Cultural competency is lacking, and we need to connect with women of color to produce much better outcomes. And perhaps we need to attach midwifery students to residents during their training so that both of them see both sides, and this will increase respect in both fields.
Thank you. Thank you.
Yeah, great idea.
Okay. Thank you. These are great groups. Lisa's group. Lisa's group.
Hi. I'm going to report because we were a very small group. There was only 4 of us. And we basically talked about how people need to know what the shocking disparities are that hospitals and other centers need to have advocates in place so that women and Black women can have someone to talk and advocate for them and to intercede on their behalf when people aren't listening to them. And then the final point was that even with education and even with people in the field, it's shocking how much we don't know about the birthing process. It's shocking that we've gotten so far away from knowing our own bodies and understanding how things can be, should be, and how they cannot, should not be. So that we need to get back to understanding our own bodies and knowing ourselves so that we can be our best advocates.
Okay, thank
Great.
you.
Thank you, Lisa.
Thank you, Lisa. So I just got a little chat, and I'm going to say it now in case some of you have to leave, and I'll say it again. And the reporters, at the end of this, we're going to show a slide with the UNA USA Westchester email. Can you please email your notes if you can? That would be wonderful, because these are great ideas that we don't want to lose. So thank you. And now Marcia, we're going to go to Marcia's group. Who was the recorder for Marcia's group? Marcia, you're muted.
Gina's our rapporteur. Gina?
Hi, everybody. So we had a very impressive group. Just to touch on the highlights, our first share was from a physician who really emphasized some things that were already touched on by our speakers today. We need to re-educate doctors and to reshape the way that they approach care and listen to their actual patients. And she made the point that a lot of doctors, even though they see the data on biases and racial discrimination, won't themselves admit that that their patients are treated differently. So really retraining doctors, but then the flip side of that, empowering pregnant people to be able to say, I don't feel heard, I don't feel safe, I don't feel like my pain is being listened to. And the note of educating the public, we also had a person suggest we utilize our community spaces, including churches or religious places of worship, to educate pregnant people and the people who love them on how to advocate for themselves, when to speak up, when to go back into the doctor to get checked out. We had a trauma nurse who talked about having trauma-informed care and addressing pre-existing trauma in the birthing process, the importance of that. And then a final suggestion from one of our group members, Nicole, to compensate midwives for births at the same rate that we compensate hospitals. It's a much, it's a much more, well, they don't get compensated at the same rate. It's less money. So kind of closing those gaps, normalizing home births, normalizing birth outside of the hospital, and making sure that people know that there are other options available to them. And then also taking some of the really burdensome regulations on midwives out of the equation.
Thank you. So I'm going to ask the groups to report a little less time because we're running out of time, but these are great. These are great suggestions. I'm so excited. Barbara's group, Barbara, the reporter for your group.
Corinne Whitaker is going to do our report.
Thank you.
And I'll try to link it back to some of the things that have already been said because we touched on some of those same issues. But part of what made it a meaningful experience is that we had two personal shares. Someone for whom geriatric pregnancy, the risk factors there were missed by health providers, both specialists and broader. And it was hard to get an appointment until after a miscarriage took place, which is just an indication of a need to involve the broader health sector and to take things seriously and pay attention. The other was with all the resources that we have, we can't seem to solve this problem. And yet, in the case of another group member, her grandmother used to walk into the woods and deliver a lot of babies. And it's that kind of a be present that is missing. We did mention and expressed real interest in the idea about training with midwives and other health professionals, as well as midwifery-led care. and touched briefly on that because we had Department of Health internationals and civil society groups, the need for the fact that midwives in many contexts are more than just maternal health. They become a health source for women. So to recognize that they have an even bigger role potentially to play. The need to, again, use those community spaces to be sure that we mobilize support for women, including men and men's community spaces and men's role in supporting women. And that the schools is one of the areas that we raised. And speaking to the question of what we do and don't know about our bodies, we talked about the need to examine what are young women learning, where are they learning it, and how can it help them to prepare themselves overall for good health, as well as pregnancy and delivery, if that, they make that choice, and to be advocates for themselves within the health system. So we also spoke about the importance of the legislation, following up on that as a concept solution, and the need for a multifaceted response, and also addressing the WHO problem with the US withdrawal.
Thank you, thank you.
Yeah.
Minnie's group.
Hi, yeah, I was the one who took notes. We had 7 people. It was very interesting. And very briefly, to keep to 1 minute, there was a suggestion to have a more holistic approach to birth in New York City hospitals, and holistic education for physicians, and more teamwork. We had a physician, we had a midwife, we had people from different walks of life, and also there needs to be behavioral changes so that for physicians, so that medical communities work together. And also the president of the chapter, Johanna, was in our group, and he gave a great idea, and I threw the ball back right into his court, like to come up with a position paper to get across, like how can we work together, especially in our state and New York City, to reduce the rates. And he said that maybe one of the outcomes we all agreed upon is, after this, to come up with a brief task force, or just for this, to come up with a position paper to outline what we can do. And again, we all agreed that local efforts really make a great impact. And how can we, NGOs, academia, the various agencies come together? But the one thing which really came out, which I would like to strongly say, it kind of resonates with the other groups, that teamwork is important. We need to listen, and we also need to see how can the midwives have privileges at the local hospitals, and how can the doctors agree to work with them more, because it's very comforting for a woman to have her midwife with her, because one of the challenges is midwives do the needful, but then in case of a hospitalization, they are not there. And this pregnancy and childbirth, as we all know, is a stressful condition. It doesn't depend on your level of education or your profession, but it always helps to have a familiar face around. So that was from our group. Thank you.
Thank you. Angela's group. Angela's group.
Hi. Devron is going to be our script.
Okay, great.
All right, so yeah, the conversation was heavy on PR in the matter. So investment in marketing is very key. Information sharing is very key, and to say a central repository as it pertains to women's health. There needs to be an organization who can send out e-blasts in a place where people can come to know more. There's also the need to garner financial support. So putting some funding behind the subject matter experts. And we also, came up with, how we need to have faith-based and community-based organizations help us. And a couple of people have mentioned how we could, start grassroots movements such as these. And then those grassroots movements can then help create form letters to pastors and community people who can then help us out with phone bank outreaches or robocalls but it was also mentioned during our session where we feel like things such as palm cards could have a little more impact than robos. So Angela, let me know if there's anything else that we need to kind of touch upon, but that's what I pretty much have.
No, you did a great job.
Thank you.
Thanks,
This is
everyone.
great.
Thank you.
This is great. We have an overlap and we have new ideas from each group. It's wonderful. Nubia's group.
Yes, so Laura Manara is going to be reporting from us. That is the rep from Andrea Stewart Cousins' office.
Yes, so our group had 3 main points that we discussed. So the first was to reiterate that medical workers getting trained by midwives being a standard best practice, across the board as being really vital. The next one was just the importance of implicit bias and the system itself not supporting women as they're pregnant and giving birth. And we had a doula from North Carolina in our group that was talking about some of the difficulties in her region with a local hospital that is requiring them to pay really high, what can become really high fees, and how that's affecting care for the families. So we came up with some possible solutions for that, like to petition the local state elected officials, which they're already doing, and also making sure the families can advocate for themselves and the changes that they've seen, and maybe having a rally and giving the families, allowing them to voice their concerns on the matter.
Thank you. We're so happy that you came here. And Angela Stewart Cousins, I apologize for mispronouncing your name before, but she has your ear, so this is great.
Yeah.
Colleen's group.
Hi, it's Marianne. So we also talked about the rich resources that we found out about in Westchester. Most of us did not know about all of them, and it would be great to have some kind of connect mechanism so that the families in Westchester would be able to find out about all of these great resources. We spent a lot of time talking about doulas and the wonderful work that we all know doulas do, whether it's prenatal, birth, mental health, lowering complications. New York State Medicaid does reimburse for doula care, but we found out it's very low payment. So that might be something that needs to be looked at, that would need to be evaluated. And Senator Amy Paulin from Westchester County was the author of that legislation. So Westchester, that's your action step. And then we finally just started to talk about education and dismantling the system in education. And we need to start with ourselves and curriculum at schools that train different healthcare providers.
Thank you. And Nicole's group.
Yes, this is Carla Horton reporting for Nicole's group. Number one consensus would be around the need to communicate and educate about the resources that are actually available. Like someone from the sharing shelf, Jerry Goldberg said, we could have come up with a car seat for a family that needed a car seat, so that more information about just what is available to meet emergency special needs. There was some concerns about the intersection brought up by me about domestic violence and maternal health because of the tremendous confluence of DV escalating during pregnancy. So that was something I brought up. Interest in understanding that there's the trauma, not just of the birth, but with the entire healthcare system. And then we really called out, one of our members is a midwife, the only one who really works in the field to any degree, talking about how the C-section rate at St. John's is 42.6%, but Phelps and one other hospital are around 22%. And so that a tremendous advocacy needs to happen around, reducing those, certainly the 42% number, and that advocacy is something that we could help with. The thing that resonated was that women have a right to be talked to and that women have a right to be listened to. They have to be heard. And that we ended with talking about what Gina referenced earlier about the need to reach out in community spaces. And people mentioned salons, churches, nursery schools. I would add to that pharmacies, you know, the grocery stores are places where people are going all the time.
Thank you. And my group, Lisa?
Yes, hi, I'm Lisa. I'm reporting for Ronnie's group. We had a few local legislators in our groups. We focused a lot on legislation we could try to, I guess, have an action item around. One on the state level, which was the midwifery birthing center bill that had passed, but now it's stuck in regulations. Midwives and birthing centers are different from hospitals, but the regulations, I guess, in Article 28 are saying that the birth centers have to have the same regulations as a hospital. So just more advocacy or action items or getting on task forces. So yeah, the state legislation understands that the midwifery care, the birthing center is different from a hospital and it shouldn't be under the same regulations as that. And also then looking at the local level, what you can do with your legislators. I think someone had said in Westchester, they're passing some legislation for home visits after birth. I think Ronnie had called it the graced postpartum wasteland, since there are no visits after the birth until 6 weeks that are paid by insurance, unless you have a C-section. But just trying to fill that gap to have either home visits, or with COVID now we have televisits, or even for them to have hospital or doctor's office visits, but for that to be paid and just be considered a routine expected normal care. So it's a big ask, but maybe on a local level, different kind of fill in the gaps could happen as well if we take that action item.
Okay, did I get all the groups? Is there anybody who didn't report? We got all the groups. Well, thank you. This was, I think it surpassed our expectations in terms of the action steps and what we can do. And I am going to, you will all be getting a report about this meeting, and I'm going to reiterate, will the reporters please put your notes up, send them to UNA, USA Westchester. The email will come out in a moment so that we can have all those wonderful reports, and we can send you all out a report on next steps. And I'm going to turn the program over. The president of UNA USA Westchester, my neighbor and friend, Yana Edwards, open the meeting, and I'm going to ask him to close the meeting.
The proud president of UNA Westchester. You know, I am in awe. This was fantastic. And again, thank you to our panelists, planning committee, and participants. There was a wealth of knowledge shared today that will help us to continue to advocate for equality in healthcare. A report, as Ronnie just said, will be sent out to the participants that will be outline our next steps. And I'm hoping that this group that has come together today, especially the committee, keep the team together, because Dr. Murthy had said to me, being a man on this panel, basically, you know, she's putting me out front to really advocate for the women. And I know my group at UNA Westchester knows how I feel about going forward. Thank you to our members for joining this evening. If you are not yet a member, please register on the website unausa.org or send a message to us at unawestchester@gmail.com. The introductory rate is only $25 per year, and student memberships are free. So I would encourage all of you to join us. And I want to apologize to Tara Rosenberg, who has been an advocate or a friend of Mount Vernon's for years when she first started. And I'm glad to see, Tara, that you're still in the business and you're very, very successful. So again, thank you very much to all who participated. Enjoy the rest of the evening. Peace and blessings to you all. Thank you.
Nicole, can you put up the slide that shows the website and the email address, please? There it is. Okay, great.
Just leave that on for a minute and we can all say goodbye while you're taking down any information you need.
The president, may I say to Ronnie that she did a very fine job.
Thank you, Ronnie.
Appointed person, Mr. President. You know, I like to get my point in. And Ronnie did a wonderful job. And thank you, Ronnie.
Thank you. Thank you. I don't know who said that, but thank you very much.
That was Brenda. That was Brenda. It was a great program. Thank you all very much.
The program committee, I have never worked with a committee that was more organized and right on target and made sure that we had our I's dotted and our T's crossed. It was, and creative. It was just amazing. It was a wonderful experience. Now I can breathe though. I don't have to be nervous.
Thank you all.
Ronnie?
Yes.
Colleen,
It's Jackie.
Sorry.
I'm sorry. I just want to know, you want us to send our notes to the Gmail?
To
Yes.
the, I can't see it now because it's
UNAWestchester@gmail.com.
yes, the email, UNAWestchester@gmail.com. So if you have to type them up or if you just take a picture of them and send it as an attachment, whatever easiest. If you have a scanner, whatever, if you wrote them on a computer, whatever's easiest, that would be great.
If you also have questions or resources to share, that's a great way to stay in touch with us and let us know what's on your mind. And you know, anything you want to share with us, you could send to that Gmail account.
Nicole, are we going to send those resources out to everybody? The list of resources?
Yes, I think with the report, we're going to send a list of resources, but there's also a list of resources, I believe, that came out with your registration approval, I believe.
Well, there was some resources on the flyer itself.
Flyer, that's right.
Right. Yeah, journal articles and newspaper articles, and they're worth reading. And also there is a documentary called Death by Delivery that's on YouTube that we may have a follow-up session looking at that and talking about that.
Yeah.
There was
We'll keep
also a
everybody
question
updated.
about access to a recording of this in the
We
chat.
have a recording. Nicole, can we send that to anyone who requests it, or how does that work?
What we normally do after our events is try to make the recording available on our website. It just, right now, the Zoom recordings are taking a little bit of extra time to process because of COVID. So many people are doing Zoom recordings, but we should have that up onto our website fairly soon.
So we can wrap it up?
Yes. So, yes, I think, thank you all. This was inspiring. I just loved listening to, besides listening to the panelists, I loved listening to the small groups reports. They were really right on target and very exciting. Okay, so I think we can say goodnight.
Yeah, I want to thank you guys again. And Colleen and Nicole, you're a committee for life.
Hey, that's good. Yes, it was a pleasure working with Nicole and Marsha and Barbara and panelists and Ronnie. It was great. And you, Yana, wonderful. Thank you all so much.
Thank you
Thank
too.
you.
Thank you guys.
Good
Thank you so
night.
much.
Good night.
Take care,
Good night.
everybody.
Thank you, General.
Good night.